So our next speaker is going to be Dr. David Payne, who's joining us from the City of Milwaukee Health Laboratory, and he is going to be finding balance in the force with GC Susceptibility. So please welcome Dr. David Payne.
All right, does this guy work? Awesome. I'm David Payne. I'm the director of the City of Milwaukee Health Department Lab. I grew up in the South, and so I talk a little slower than most folks, but I also get really excited about science, so I talk fast when I talk about science. You never know which one you're going to get, so we'll see. I was asked to give a Star Wars themed talk about gonorrhea, which I admit is a challenge. I thought, maybe these things look like little Death Stars or something, so there's something there. Aaron told me I could not stick with the theme, but I like a challenge, so there's going to be some very tenuous Star Wars references here. Give me some credit, stick with me, we'll get through and maybe learn something. I always like to start, though, talking with some historical context. Anyone who's seen me talk before knows that I really am fascinated by the history of public health, specifically with the way that STIs were treated, with public health messaging in the 40s during World War II. So I always share a couple of these propaganda posters from the Second World War because I think they're really fascinating. In the past, public health really saw their main mission related to gonorrhea as just messaging. So here we've got a poster that was made in 1941 by the U.S. War Department, now the Department of Defense. This was found in army bases all across Europe. And for anybody who can't read it from where you are, it says, "Prostitution spreads syphilis and gonorrhea." Very simple message. And this was, meant just to educate and to tell all these naive country 18, 19-year-olds who were finding themselves in Europe that they could actually avoid the kind of risky behavior that led to STIs. This one is from the New York City Health Department with also just very important messaging for the time. This is also from the early 1940s. It says, "Syphilis and gonorrhea can be prevented and cured. If you suspect infection, go to a reliable doctor." There was a problem at the time with quack medicine, people giving miracle cures for gonorrhea and other ailments. Stand on your head, do a bunch of jumping jacks, eat 5 pounds of oranges, weird stuff. And the message from the New York City Health Department was, go see a real doctor because there is a real miracle cure. It's called penicillin, and it's awesome. And so between these two, sort of educating people about risk factors and educating people about the fact that they could seek medical care for these problems, that was really public health's major way of combating gonorrhea for a long time. But the situation evolved, and I use the word evolved carefully here, because gonorrhea learns very quickly. So I want to go through just a brief history of what gonorrhea has learned for the last 100 years. In the 1930s, we used sulfa drugs as the primary line of defense against gonorrhea. In the 40s, we saw resistance develop and started using penicillin, which was effective for a really long time, clear through to the 80s when we started to see resistance to penicillin and tetracyclines. And so in the 90s, we stopped recommending penicillin for uncomplicated gonorrhea and started using fluoroquinolones, which history keeps repeating itself. We saw resistance to those in the mid-2000s and switched to the third-generation cephalosporins, which we also saw resistance to very shortly thereafter. And around 2015, we started treating with ceftriaxone and azithromycin together, which did not last long. We got rid of azithromycin 2020, 2021, and that leads us to where we are today, where CDC has named ARGC as an urgent antimicrobial threat. We saw 3 out of 5 of these in Al Bateman's talk. We're not going to quite pick up the spare on the 5th one, but I'm going to talk about gonorrhea here. We all know, I think, in this room why it's such a big deal, right? We've got about 1 million gonorrhea infections estimated in the United States every year. costing $100 million in direct medical costs. That's to say nothing of lost time at work and other indirect costs of these infections. And so, because this is such an urgent threat, CDC wants to get ahead of the risk, so we gathered public health, healthcare professionals, and sort of got the whole team together to think of how can we coordinate our efforts to combat this and get a step ahead instead of always just reacting when drugs stop being effective. Now, CDC is focusing a tremendous amount of effort, time, and resources combating antimicrobial resistance and gonorrhea. Here is a map of the country. I don't know which board to point at. Sorry, I'm not used to being behind a podium. I like to wander. Can y'all see my mouse if I point at stuff? No? All right. Then I will just gesture wildly. So we've got a map of the country with different colored dots for different CDC programs related to antimicrobial resistance and gonorrhea in some way. The only ones I'm really going to talk about are the purple ones. Those are SURG, S-U-R-R-G, strengthening the U.S. response to resistant gonorrhea. There are 8 sites involved in this CDC program, and one of them is in the greatest city on earth, Milwaukee, Wisconsin. And that is why I'm here talking to you about that one. So SURGE is a program, like I say, that has these 8 sites that are involved in it. There are a few high-level, big-picture goals. We're not going to go super deep into it, but I want to talk about the big goals of the program. One is to strengthen the connection between public health and healthcare, public health labs, public health epidemiologists, and healthcare being hospitals, clinics, all those groups that care for one patient at a time. And the focus is on doing this at a local level, and we'll talk more about that. Another big goal of SURGE is to increase laboratory capacity for doing AST and to increase capacity of the EPIs to do EPI work like contact tracing and other non-laboratory ways of combating GC. So here we've got the city of Milwaukee. You can tell it says Milwaukee on it. If you don't know the highways, you can spot that. The Milwaukee Health Department has its headquarters right downtown, right next to the lake, and that's where the lab is located. And we work with 6 local clinics. 4 of them are Planned Parenthood clinics. One of them is a volunteer-run clinic that is a not-for-profit that treats anybody who walks in the door, regardless of ability to pay. And one of them is run by the health department itself, another STI clinic. At any of these clinics, when somebody walks in presenting with symptoms of gonorrhea and meeting certain other criteria, sorry, I'm adjusting this, seeing if I can see my notes better. They come to the clinic and they get tested. Well, they get sampled, and the sample gets sent to the Milwaukee Health Department where we do the testing. We do AST to detect resistance, and then we send those results back to the clinic. Now, at this point, it looks like we are LabCorp, like we're Quest, like we're any reference lab. The lab or the clinic sends us samples, we send them results, and that's not terribly unique. But what makes SURGE exciting and useful is that we also aggregate and anonymize those data and put them in a database being analyzed at CDC. So the clinic gets the results back, knows how to treat their patient, but we're also getting these broad population-level data sets about drug resistance in GC. So what do we get from all this? One thing is we get a lot of data. Before I was in public health, I was an academic, and so just the thought of getting these big data sets is always exciting to me. I, by coincidence, used to work in gonorrhea research, doing signal transduction studies, completely unrelated to patient care, completely unrelated to antibiotics, and I used these papers from the SURGE group in my research. So this is data that goes out to the broader scientific community to help us better understand gonorrhea and how it works. And more important, I think, than just getting data is that SURGE provides very timely data. one of these papers on the previous slide, it says that some of these other programs, the other colored dots on that map of the country, they provided data in 1 to 3 months, whereas Surge, the data has a mean turnaround time of 5 days, which for plate-based AST, where you have to actually grow the bugs, is about as close to real time as you can get. 5 days is pretty quick for a median turnaround time. So just looking at the kinds of data that we get, you know what, I think I do have a laser pointer here. Ha, there we go. All right, so I'm not gonna go in depth on the data. I just wanna sort of show you these are the kinds of things that we're doing. This is from 7 years of Surge. We did about 75,000 NAT tests, about 18,000 culture tests for gonorrhea. And you can't see it, I apologize. The different bars are different body sites. So we've got urethral, endocervical, pharyngeal, etc. We can split down, drill into the data a little bit deeper and break it down by things like age and sex. So we've got, male testing, female testing, and other genders. Other genders, the N is pretty small, so I don't like to draw really big conclusions based on that, but we do pull those data out. So, as I said, the most important part is that we're getting the antimicrobial susceptibility. Up to those 2 graphs were just positivity, does this person have gonorrhea or not? But the real key is that we're getting the drug resistance. So let me walk you through these charts and what they're showing us. These are graphs of ceftriaxone and cefixime resistance data from 7 years of Surge, thousands of samples coming through the Milwaukee Health Department lab. On the x-axis, we've got MIC, minimum inhibitory concentration, low concentrations on the left, highly susceptible, higher concentrations on the right, less susceptible. The red bars here are given, these are the CLSI breakpoints. So anything to the left of that red line is susceptible. And for both ceftriaxone and cefixime, we saw exclusively susceptible isolates, which is good. That's what we want to see. For azithromycin, unfortunately, that's not what we saw. The same setup here where we've got MICs across the x-axis. The red bar is the CLSI breakpoint for azithromycin, and you can see that we had hundreds of isolates above that breakpoint. So these are non-susceptible isolates that came through the lab. Remember, these data are aggregated from multiple years of testing. But one of the great strengths of Surge is that the data come out in real time. And so we can break this down. I'm not going to break it down all the way to real time looking at dailies. But if we look at this yearly, I think we can see a really interesting story with the azithromycin resistance. The gray bars here are total number of tests run in that year. We've got 2017, 18, 19, 20. The gold at the bottom are azithromycin non-susceptible isolates. And you can see a really clear jump in those in 2019 and continued up through 2020. And these are the ones tested in Milwaukee. I'm not going to present other folks' data, but I can tell you that the other 7 Surge labs saw very similar trends. They saw in 2019, 2020, azithromycin resistance started going up. And so, in 2020, CDC put out new guidelines for how to treat uncomplicated gonorrhea, which included removing azithromycin from standard of care. In the following year, we saw this non-susceptibility go down. So the part of me that is an academic that likes to, that used to teach intro micro, I'm really excited just by the basic science of this, that we put a selective pressure on a microbe, we saw evolution, we removed the selective pressure, we saw the population shift again. But the part of me that is in public health, that is interested in patients and people outcomes, is even more excited because I see that we're saving a drug that was headed towards resistance. Now we have that still in our back pocket for future use. So I lied to you a little bit, I apologize. I'm coming clean now. I've been using the present tense to talk about surge, and that's a little misleading because as of last month, surge is not around in the form that it has been for the last 7 years. We started off as farm boy, whiny teenager Luke, and we've gone on to awesome lightsaber Luke. Surge has combined with a couple of other programs, including GISP, to form a new program called CARGOS, Combating Antimicrobial Resistant in Gonorrhea and Other STIs. CDC could use shorter acronyms, but they don't ask me when they make them. So we're just going to call it CARGOS. So CARGOS is similar in some ways to Surge, but just like Luke, has gone through some very important changes. And I'm going to talk about what's the same and what's different. So first, with what's the same, we still focus very heavily on our clinical partnerships. The public health labs cannot do this without the clinical labs. And we're still focused on the same kinds of specimens, pharyngeal and urethral specimens. The Milwaukee Health Department Lab is still serving as a center of excellence for AST, and we're sharing our data through CDC and ARLN, including clinical data, lab data, demographic data, and things like that. One of the big differences is the breadth of this program. So there were 8 surge labs. There are 19 sites participating in CARGOS. And so we're getting a much broader geographic and demographic spread of the country, hopefully a more representative sample of what is actually out there. And one of the other big differences is we have increased our focus on suspect treatment failure. This was always a part of Surge, but is now a bigger part of CARGOS. So I'll tell you a little bit about what we've done with that. Under Surge, I apologize, the dots there are very small. The dots represent places that have sent samples for testing to the Milwaukee Health Department from patients suspected for treatment failure for gonorrhea. We had 11 over the course of our participation in Surge from across the state of Wisconsin that sent us suspect treatment failure samples. And our goal with CARGOS is to expand that and to do a lot more of that. And that's where you all come in. We need you. We need your help. There are 2 things that we would really appreciate help with. One of them that I'll be talking about is a survey from DHS, and one of them is actually sending us physical specimens. So related to the survey, DHS is working to organize a list of laboratories throughout the state that have capacity for culturing GC specimens, and we'll talk a little later about why that data will help us. But this is, I apologize, a little distracted. On the next slide, I'm going to put up a QR code. If y'all can scan it and put in your contact information, CARGOS from DHS will be reaching out in October with a survey. So that survey is going to not the survey, at this QR code, you can enter your name, organization, and email address. And like I say, DHS is going to reach out to try to find capacity for growing GC, just so that we can have a better understanding of what exists already in the state, how we can help as we try to gather more STI samples. And I'll put this slide up again at the end for anybody who misses it right now. So the other thing is actually sending us specimens. So last year, DHS put out this memo. I'm not going to read the whole thing. It's like 9 pages long. But essentially it says that cephalospore and AST can be provided at no charge to clinicians, to you guys, to your patients, to anybody except for us. We will be paying for this. We'll do cephalospore and AST in cases of suspect treatment failure for gonorrhea for clinics, local or tribal health departments. So essentially, this little graphic I put up earlier, if you have a case of suspect treatment failure, you can join this little cycle and send us samples, and we'll send you data, and we'll also put it into our big data set for Surge. The criteria for this, there are a couple of cases that that we would like to hear about, that we would like to get samples from. One is if you have a patient with persistent symptoms 3 to 5 days after treatment. One is regardless of symptoms, if a patient fails test of cure, we would like that sample to test. And also, if you have any lab results suggesting reduced susceptibility to cephalosporins. I know most labs aren't routinely running e-tests on these things, but if you have any reason to believe this from other lab data, we would like those samples so that we can confirm that and so that we can add it to our database. What do we need from you? Well, we need anything we can grow. So, you can send it to us on a chocolate agar slant, you can send it to us on an in-tray, or just send an e-swab, depending on your own lab's capacity. And this is why that survey is so critical, so that we can understand what you need. If you're a big hospital lab, you probably already have an isolate and you can just put it on chocolate for us. If you're, Podunk Health Department that has one public health nurse and doesn't have the resources to culture and isolate things, we can just take an e-swab. And if you don't have these supplies, we'll happily ship them to you. And after you've collected from your patient, we'll send our courier to pick up the specimens. We're trying to make this as easy and streamlined on your end as we possibly can. And if you're not sure which of these to send us, call us. We'll help walk through it. After we receive that specimen from you, we're going to identify that it is actually GC. We do this with traditional microbiological methods, and then with molecular methods or API. And then we'll do the AST. Again, I have to reiterate, this is all at no cost to you or your patients. This is all funded by CDC. So we'll do the AST, we'll get the results and send them to you and put them in our database. And we'll work together to get through this. The data I've shown you come from Surge primarily, but we are transitioning to Cargo, so I've got to put that up there. And this is a collaboration between the Milwaukee Health Department and DHS. So with that, I'll put that back up and take any questions.
Let me come and get you.
Kelsey Cordova, Rock County Public Health. I supervise our communicable disease team. And so not so much more of a question as an acknowledgement. It's increasingly difficult to identify suspected treatment failures with gonorrhea because we're not getting information through our contact tracing or partner elicitation, so we can't rule out reinfection, which is the common source of kind of those persistent symptoms, or patients are lost to follow up prior to test of cure. So there's a lot of challenges on kind of our end too, and even recommending specimens being sent.
Right. Yeah, I agree. I recognize that the folks out there doing the what is it, shoe leather work, out there knocking doors, you guys have a really hard job trying to connect with these people who don't, for some reason, want to talk about their sexual habits and histories. I get it. But if you ever have a case that you're not sure, is this suspect treatment failure? Is this something that would fall under Cargos? Please give us a call. The Cargos coordinator at the state, I should have her contact here, but I don't. Her name is Kyla Quigley, but if you reach out to me, I can gladly set you up a conversation with her.
Any other questions?
Just a quick question, because I know we send to you guys for gonorrhea susceptibility testing, and those cases are almost always suspected treatment failure. So is there a specific separate order that we need to place indicating it's suspected treatment failure? Because I noticed Milwaukee wasn't on your map, and so I wondered if there's a disconnect between our intent and the information you're receiving from us.
I'll check with our LIS person to make sure those are getting counted in here. I think so I asked him to put together the figure very last minute, and I just said, give me all the AST we're doing that's not from Milwaukee. So
Okay.
I'm guessing that's why, is that it is
Got it.
a map failure, not a system failure.
Okay,
But
just
let's
want to
connect
make
and
sure if there's a separate order that should be placed or
Yeah.
that we should be looking for. Happy to do that as well.
Yeah, I'll confirm that.
Thank you.
All right, not seeing any other questions, I will thank Dr. Payne for his presentation. It was very interesting. And the best Star Wars slides.